Demand for health care coverage always seems to be rising, along with health care costs. And now some insurance plans are setting limits on what they will pay for certain medical procedures. Coverage caps that could end up costing you more money. Bertha Coombs has more.
CalPERS, the California Public Employees Retirement System, was fed up with paying wildly different prices for the same medical services.
One hospital could be charging us $15,000 and another hospital, True Number, was charging us about $100,000 for the same procedure, for the same length of stay, for the same quality outcomes. That's what drove us to take a broader look at this and say, what can we do to standardize that?
So CalPERS took a bold step. They set a limit of $30,000 for a knee replacement and told members where they'd get the best care for that price. The savings the first 2 years, $5.5 million. Members shopped around, and that forced area hospitals to respond.
A lot of the high-priced hospitals reduced their prices. They didn't want to lose these patients. The low-priced hospitals did not reduce their rates. They just stayed where they were.
Under the Affordable Care Act, health plans can't set spending caps when it comes to overall coverage. But the Obama administration earlier this month said that CalPERS and other plans will be allowed to set spending caps for individual procedures, at least for now. For standard procedures like knee replacements and colonoscopies, price limits are a good tool to help bring costs down, says Berkeley professor James Robinson.
They'll try to make sure that you can go to a moderate-priced provider, and if you want to go to the more expensive one, that's your right. We're not stopping that. We're just saying you have to pay the difference yourself.
But it only works when there's an emphasis on quality care, says CalPERS Ann Boynton.
I think the danger is a purchaser might be inclined to implement a program like this, but not have all of the appropriate support systems in place that make it work for the patient.
The Obama administration will issue a final rule on price limits later this year. Bertha Coombs, Nightly Business Report.
Joining us now to talk more about all of this, Craig Garthwaite. He is an assistant professor of management at Northwestern's Kellogg School of Management. His specialty is healthcare. Craig, nice to have you back with us. You know, I don't think too many people would argue that we want to get our healthcare costs down, and this is one strategy to do it. But are we at risk here of getting low prices, but also coming with it low quality care? What about quality care?
So I think the representative from CalPERS was perfectly correct on that this only works if you give the patient enough information to pick the right hospital that offers a quality, and you set the price at a point that there are a number of high-quality providers. And let's be clear, you can do that. There's such dispersion in the prices paid across hospitals that there's lots of places you can get these relatively routine procedures like a knee replacement at a lower cost than you might currently be paying.
But where do you get if you can access the cost information, where can you get the information on quality? How long a person took to recover, the incidence of infection, the incidence of complications and things like that?
Yeah, it's going to be incumbent upon the insurers that want to implement this reference pricing scheme to give that information to their customers. And that's only going to come through the insurer and through us having a really good sense of what quality means in this setting. So infections after surgery are one case, but also you want to think about if you're getting your knee or your hip replaced, how long does it take for you to get back to pain-free daily living, the goal of that? And those types of patient-reported outcomes are things that we're going to have to include in this system.
You know, Craig, it's very difficult and confusing for many people to understand the current healthcare system, and now we're adding on all these new rules and terms and policies. You know, talk us through about what kind of education we're going to need for consumers, the patients, in all of this, so that they do well. We've seen in the financial education area, a lot of people still don't understand how a 401k works, and that's been around for a long time.
Yeah, no, it's hard. You know, we say many economists can't really understand the healthcare system either, so it's quite difficult. But I think the goal here is to pick a set of relatively self-contained procedures and provide people with tangible ideas of what quality is in this setting. So I think we can understand things like how many more infections do your patients have than others, how fast do your patients get back to being able to have pain-free living than other people, and those are the types of outcomes we want to look at. And I think there's going to be a lot of effort over the next few years, keeping in mind that patients will always have the option to not buy one of these insurance plans. There's going to be a trade-off here. You're going to choose, do I want to pay a high premium and have lots of flexibility and no reference pricing, or do I want to have a low premium, and I'm going to be forced to shop around a bit to be able to get the best price. This is the choice we're going to face on the exchanges as we try and control healthcare spending.
As a matter of sort of pricing theory, Craig, when a third party is paying for something, you don't care very much what the price is, what the cost is. This seems to be driving at the idea that I, the insurer, I'm going to make you, the ultimate user, very aware of what the cost is, and you're going to have to bear more of that cost. Is that potentially a good thing in terms of bringing the market to bear to bring prices and costs down?
We certainly want to have a little bit more of a situation where the patient is responding to price signals within healthcare. And so we want to do that. We want to do it in a way in which the patient can make an informed decision. And that's why we want to do it and pick these types of relatively self-contained procedures. We don't want sort of people to pick their care coordinator for type 2 diabetes based ultimately only on price, because we don't think patients have enough information for that. But we can identify a set of procedures like an MRI, like a colonoscopy, which we think are relatively self-contained episodes, and patients can shop on price. And that really is the only way we're going to solve a lot of our healthcare spending. It's in some ways a simple problem. We need to either consume less healthcare or pay less for the healthcare we consume. And this is one attempt to get at the price question.
Boy, it's a whole new landscape. A lot to learn here. Craig, thanks so much for explaining part of it to us. We really appreciate it.
Thank you.
Craig Garthwaite, he's Northwestern's Kellogg School of Management professor.